Severe acute ataxia ranged days to weeks. Systematic disorders, autoimmune disorders, paraneoplastic or primary metastatic tumors, infections, nutritional disorders should be considered. SAPAN may be acronym for systematic disease, autoimmune disorders, paraneoplastic, infections, and nutritional disorders. Blood CSF tests for the diagnosis of subacute ataxia are as follows. Erythrocyte, ammonia, liver function, copper, ceruloplasmin, lactate, pyruvate for systematic disorders, GAD, ANA, anti-gliadin antibodies, anti-TPO antibodies, anti-TG antibodies for autoimmune disorders, Yo, Hu, Li, Mar, and TR for mGLR1, VGCC, VGKC, CRP5, PCA2, CASPA2 for paraneoplastic syndrome, RPR, HIV, JC virus, and 1433 protein, prion protein for infections, liver function, ammonia, vitamin B1, B12, E for nutritional disorders are essential. MRI and CT provide useful information for the diagnosis of subacute cerebral ataxia. As you can see, hypoparathyroidism, JC virus infection, Wernicke encephalopathy, Creutzfeldt-Jakob disease, acquired hepatocerebral degeneration, superficial siderosis, neurosyphilis, and CNS lymphoma may be diagnosed or may be noticed by the characteristic MRI findings. Interestingly, autoimmune-related subacute cerebral ataxia patients often show pure, mild to moderate cerebral atrophy. Paraneoplastic cerebral, I'd like to show our patient who have paraneoplastic cerebral degeneration related to anti-MAT antibody. As you can see, she showed a significant cerebral involvement prior to IVIG treatment. However, post-IVIG treatment, she showed a dramatically improvement. We should not overlook treatable cerebral ataxia, particularly in a subacute ataxic patient. This part introduced the key points for differentiating between cases of acute and subacute cerebral ataxia. Polling question for the audience, which is the correct sentence? When we see a patient with acute cerebral ataxia, vascular toxic infection causes should be considered. Systemic autoimmune paraneoplastic infectious and nutritional disorders should be considered as causes of subacute cerebral ataxia. MRI and CT can provide useful information in the differential diagnosis of subacute cerebral ataxia. Patients with subacute ataxia due to autoimmune abnormalities can often show the abnormal findings confined to the cerebellum on MRI. Patients with subacute cerebral ataxia often have a background condition that can be treated. Finally, I'd like to discuss the diagnostic approach to chronic progressive ataxia. If we look at the chronic progressive ataxia, we should consider the hereditary ataxia, including autosomal dominant cerebral ataxia, ADCA, autosomal recessive cerebral ataxia, ARCA, X-linked ataxias, and mitochondrial ataxia. It's important to make sense of SCA clinical features. Even nowadays, hardening classification of ADCA in 1982 is still useful in the clinical setting. ADCA1 is a cerebral ataxia with variable additional signs such as an SCA 124, 8, 10, DRPLA, and so on. ADCA2 include cerebral ataxia with pigmentary macular degeneration, SCA7. ADCA3 is a pure cerebral ataxia symptoms, including SCA5, 6, 11, 30, 31, and so on. Interestingly, several studies have shown that even ADCA3 patients show the non-cerebral ataxia symptoms. This slide shows the geographical distributions of SCAs. As you can see, SCA3 MJD is the most common polyglutamine SCA worldwide, accounting for 20 to 50% of families with a dominant ataxia. Owing to the lack of systematic studies, the prevalence and geographic distributions of SCAs caused by non-coding expansion or conventional mutations, yellow or rectangles, are still fragmentary, like this one. MRI for the diagnosis of ARCA and X-linked ataxia is also important. As you can see, Friedreich ataxia patients show the significant atrophic changes in the cervical code, and Wilson disease patients show characteristic signal changes in the midbrain on T2 weighted images. Cerebral tendinous xanthomatosis patients show the increased signal intensity in the dentate nucleus in the cerebellum. Fragile extremor ataxia syndrome patients show the increased signal intensity in the middle cerebral peduncle on T2 weighted images. I'd like to summarize the importance of sporadic late onset cerebral ataxia, okay, including sporadic adult onset ataxia, multiple system atrophy, and progressive supranuclear palsy. Sporadic adult onset ataxia, SAOA, is a non-genetic neurodegenerative disorders of the cerebellum which manifest with progressive ataxia. There is no generally accepted terminology of SAOA. Idiopathic late onset cerebral ataxia includes MSSC and SAOA. In Japan, several investigators studied idiopathic cerebral ataxia to establish the clinical diagnostic criteria. This study investigated 346 consecutive patients with the core feature of the criteria, sporadic, insidious onset, and slowly progressive cerebral ataxia in adults, and cerebral atrophy on brain imaging like this one. Interestingly, 80.2% classified as an SAOA from idiopathic late onset cerebral ataxia. This study also shows that 39.7% of patients with an SAOA showed a pure cerebral syndrome. In other words, 60% of patients with an SAOA showed a non-pure cerebral syndrome. These findings also confirmed by several studies performed in Western countries. As you can see, clinical examination revealed additional extracerebral involvement, including pyramidal tract signs, decreased absent ankle reflexes, decreased vibration sense, and mild urinary symptoms. I'd like to move on to the MSA topics. Severe autonomic failure, such as an urinary incontinence or a severe orthostatic hypotension, is an essential for the diagnosis of multiple system atrophy, as you know. The understanding of red flag sign will be very also important for the diagnosis of MSA, such as an orofacial dystonia and disproportionate anatomy during the early course of the illness, and cold hand sign, particularly stridor. Stridor may be also closely associated with sudden death. MRIs also provide useful information for the diagnosis of MSA. A one-year follow-up study revealed the discriminative value of middle cerebral peduncle and hot cross-band signs on MRI in patients with sporadic late-onset cerebral ataxia. Yellow arrow showed the hyperintensity in the middle cerebral peduncle, and blue arrow showed the hot cross-band sign, like this one. In this study, among 80 patients with sporadic late-onset cerebral ataxia, 26 had MSSC, 22 another diagnosis, and 32 no diagnosis at the end of the follow-up. In conclusion, MCP and SCP signs were more frequent in patients diagnosed with MSSC than in other patients had high specificity and positive predictive value for the diagnosis of MSSC. However, even in a patient with cerebral ataxia and autonomic failure, we should consider the possibility of SCA. In this study, mutations in SCA genes were found in 22 of the 302 patients clinically diagnosed as Korean MSA patients. Particularly, SCA 17, 2, 6, 3, 1, and DLPLA should be considered. Recently, several studies demonstrated that, particularly from Japan, there are progressive supranuclear palsy patients with predominant cerebral ataxia. This is a very, very good video from the journal Movement Disorders. Okay, this patient showed a significant supranuclear gaze palsy. In addition, this patient showed the significant involvement of the cerebellum, like this one. Limb ataxia evident in these patients. In patients with PSP with predominant cerebral ataxia, superior or cerebral peduncle hyperintensity on MRI characteristics. But the number of PSP with predominant cerebral ataxia is limited. So we will need a collaborative study to establish the clinical concept of PSP with predominant cerebral ataxia.